I'm Dr. Dinesh Pendharkar, cancer specialist working in Delhi. The biggest challenge in cancer care world over is access to care. The access means multiple things. The access means physical access, that you have to travel to some distance to get the treatment. The access means a financial access. Patient cannot afford cancer treatment, it is really costly today. The access means cultural barriers, because if a patient from say far off West Bengal travels to Delhi, he might actually have a challenge with staying in Delhi, with cultural challenges, with language challenges. So there are multiple access issues, and the biggest problem in cancer care in access is patient doesn't travel alone. He has to go with a family. Then there are 2 to 3 people required to take a decision on the next line of treatment. So that's also an access issue. So there are multiple access issues which actually complex the care of cancer. So even if patient has an access to a physical facility and a financial capacity, still cancer care is a difficult issue. If we want to solve a cancer care problem, we should probably solve the issue of access at every level, be it financial, be it social, be it economical, be it cultural, be it government system. So all these areas needs to be considered to solve the access issue. The way forward, I personally feel in access is, see, the biggest challenge is physical and the biggest challenge is finance. So the physical issue can only be solved because that by bringing care to the periphery. And if you have to bring care to the periphery, it should be as close to the patient as possible. That's a physical access. And financial access is government has to come out, which government fortunately is coming out with lot of financial solutions to assist the cancer patient financially in his treatment, in his journey of cancer care. So if these two issues are resolved, I think the policy has to bring the care to the periphery. And in India, the periphery actually means the district, because district is a place which a patient is absolutely comfortable to visit. So if a person from a Delhi district has to visit a hospital in Delhi, he is very comfortable. If a person from say Jaisalmer has to visit a hospital, Jaisalmer district hospital will be the closest place for him, and at the same time the district headquarter being an administrative headquarter, every person is familiar to go to the district hospital. He doesn't feel any challenges. He has relatives, he can walk, the distances are small. So probably district hospital should be the unit which should be empowered in a specialized care. Fortunately, I had experience of working at multiple places in the country. I started my journey with Tata Hospital in India. I worked at AIIMS Delhi. I did practice in Indore, Bombay, Delhi, again in Delhi, presently at ICD Healthcare. So the idea of all this journey and the results of all this journey was patient is not able to access the care. He can come to a cancer hospital once, but he cannot come again and again. This needs a solution, and we cannot have cancer hospitals in all the districts. So we started working on this issue long back when I was in Delhi, and the first issue we tried to resolve for railway hospital. Same problem was with the railway hospital, that the railway patients who are supposed to be taken care by railway hospital were not always willing to go out of railway hospital for treatment. So we started a unit of cancer care in Central Hospital Railway Delhi with a general duty medical officer taking care of cancer patients. And I gained experience from that, and it became so successful that in the same fashion it is being run for last now 14 years. That shows that the model works, that you can use a general practitioner for the cancer care. So as I said, if we have to bring care closer to the patient, we have to empower the district hospital. We know we cannot increase the number of doctors. We know we cannot bring a specialist to a district hospital. So we have to create such a system that which will still offer a help to a cancer patient in the district hospital. So I rolled out one model of experiment in Ratlam district hospital, where I empowered a doctor to do chemotherapy, and with my backup they started looking after cancer patients, offering free anti-cancer drugs to government schemes. Then government of Madhya Pradesh came with an idea that we would like to do cancer drugs free in all the district hospitals, because every care in a government district hospital is free. So I sat with the government of Madhya Pradesh and we evolved into a program which is now known as District Cancer Care Program and functioning in 4 states of India: Madhya Pradesh, Odisha, Rajasthan and Himachal. Practically in all districts of these states, and the program has been coined as District Cancer Care Program, by which we have taken one existing general duty medical officer who is a government employee, who is a general physician, has been retrained into looking after cancer patients over 1 month by me, and he goes back to the districts and starts seeing cancer patients. 2 nurses have been trained in doing chemotherapy. So today what is happening is, a cancer patient from the district, he is free to visit any hospital, but when he lands up in a district hospital, he is being seen by this doctor. The doctor examines the patient, takes the review of the patient, and the patient is brought to a tumor board which comprises of me as an oncologist, 2 of my colleagues and the group of the doctors from the state, and then we decide what is the next course of action for this patient. Generally, when this doctor puts this information on a group, he is replied as fast as half an hour, and if he does not get a reply within half an hour, he is supposed to call and get an answer depending on the emergency of the situation. The whole idea is, this doctor may not be well trained in a month, but with every patient he is seeing, he is being trained. So he is being continuously trained, and you can imagine if there is a doctor who is being continuously trained, with every patient seen, his skills are going to improve. The government has chipped in with phenomenal input into this program. All these doctors have been designated as district nodal cancer officers. Majority of the hospitals, especially all hospitals in Odisha, all hospitals in Rajasthan, carry a signage that this doctor is responsible for cancer care. There have been specialized beds allocated in most of the hospitals for cancer care, where patient gets chemotherapy. All these states have included anti-cancer drugs in the list of essential drugs, and the drugs are available in the district hospitals, and all these services are free, including investigations being done for cancer patients are free. So a patient can walk into these districts and take cancer care. If patient requires services which cannot be offered in a district hospital, patient is counseled appropriately by a local doctor who knows local cultural things, who knows local language, who is a local person, can be visited frequently by this local person. He counsels this patient appropriately that please go for surgery, you will benefit from surgery. So now you have a person in the district who is explaining you why surgery is important for you. You do not have to go to a big hospital to listen this, and then you can decide where you want to go for surgery. You are free to go. Generally patients go to nearby cancer hospitals which are approved by governments, but the idea is patient is getting a proper counseling in his own district. So this whole program has been coined as District Cancer Care Program, and it is running well. It has been audited by multiple agencies, including Additional Secretary Health, including by agency of Ministry of Health. Practically even some international agencies have come and audited the program, and everybody was really appreciative of the program. And when they spoke to the patients, all patients were very appreciative, because it was saving them from majority of the access issues. So as I said, the major issue in cancer is an access issue. So here government is pitching it with free support, free anti-cancer drugs, free service. Patient has to travel a smaller distance, and patient is still being referred to appropriate cancer hospitals as and when required. So probably this is a model of cancer care delivery, which now I personally feel is a health care delivery model, which we have exercised in 125 districts. Close to 17% of districts of India, government district hospitals, is working in cancer and can serve as a model for all diseases where government finds it as a priority. So maybe it will be a mental disorders, for example, government thinks this is a priority, they should pick up one physician, one mentor, appropriately give him 24/7 backup, and probably this is the way forward if we really want to actually think of universal health care in this country.